I just wanted to do a poll real quick of, are there administrators or nurses in the audience? And care managers? Okay, perfect. I just want to make sure I cater to this. So just to put into context, I do work for a private multi-specialty healthcare clinic, physician-owned in Salt Lake City, Utah. And between our, we're a part of the MSSP, so Medicare Shared Savings Program, Track 1 Plus, of our ACO. And so it'll kind of go along with this presentation. So the overall problem of our organization was that our patients were no longer trusting our healthcare providers. So as they came and saw our providers, they've transitioned to a hospital setting, went to a SNF, and at one point or another, they would come into our office setting. Their meds have been changed, other healthcare providers have been involved in their care, and in that 15 minutes, our healthcare provider would indicate, I had no idea that this all happened with you. I don't know anything about your new meds, your new care journey. So they became a brand new patient. So it made our patients actually lose trust in that healthcare provider, and then leading them to go back more to the emergency or hospital care, because that was the provider that that saw them last. So they felt like, well, my primary care doesn't know what's going on with me. I'm going to go back to the hospital because I know that that's the last person that was going to involve my care, and they'll have everything. And unfortunately for us, our ACO metrics, when we measured it in 2013, our readmission rate was measured at 23%. So I think at that time, the national average was about 20%. And so they wanted to implement that transitional care program. So our biggest platform was the TCM program. So TCM, I think you guys know about it, the CEMS guidelines for transitional care management. This was our evolution, is that how do we solve this problem? So they just asked me and said, hey MJ, is there any way you can figure out how to implement this program? And it realistically was not for our ACO initiatives. It was just so that we can build trust back into our healthcare providers for our patients. We started with post-acute partnerships, so we wanted to help get partnerships with home care and hospice agencies, and then following skilled nursing facilities. We felt that in our community, if they're transitioning to these settings, we need to have partnerships to enhance our communication. But unfortunately for us, even though we did our transitional care program, this is amongst 175 different providers. For our ACO, we oversee 16,000 traditional Medicare lives, but for Granger itself, our organization, we probably have about 360,000 patient lives that we were overseeing, and it stretched across the state of Utah. So we really had multiple health care systems that we had to work with, as well as maybe over 100 or so SNFs, and maybe 200-ish home care and hospice agencies. So you can see that for us, there was a lot of unknowns. So for hospital systems, for us, we were able to identify where all our patients were through our transitional care program. However, the hospitals didn't know who those patients belonged to. So we knew where they were, but they didn't know who they belonged to. So we needed to establish a great relationship with the hospital systems. The other component, it was that a lot of care managers, and we didn't know this from an outpatient standpoint, we didn't recognize that it wasn't in the care manager's job description in inpatient care to help identify the primary care and help schedule appointment before they leave. I do think that a lot of the job descriptions have enhanced since then, but this is back in 2014 when we started engaging. The other component was that disposition. In discharge summaries, it's very generic. It'll say discharge to SNF, discharge to home care, discharge to home. For us, that was not helpful for our TCM program because we had no idea what SNF they went to. So we're tracking these. So a lot of times it became like a missing persons case for our patients. And then overall, the recommendation that was indicated in all the discharge summaries was to follow up with your primary care in 1 to 2 weeks. A lot of times the patient didn't recognize that the primary care needed to be involved in their health care, and there wasn't an advocate for them to schedule these appointments. For skilled nursing facilities, sorry, this also got like super loud. For skilled nursing facilities, we were not able to identify where they went, and when we did identify, we would go in through the case management. So a healthy tip would be in hospital systems, if you're doing a transitional care program, just make sure to review the case management notes, because that's where a lot of the documentation is going in on where they set up, say, first, second choice for SNFs or home care agencies. So that's what we had to discover in our setting. So once we identified where our patients were in these SNFs, we didn't have a contact in these facilities, so we would just call daily to the receptionist or whoever picked up the phone, and they genuinely would not tell us if our patients reside there, right? HIPAA violation, they're like, we never had primary care ever care, so I'm not telling you. So this was a daily thing that for us, over a year, I wanna say. And then in the end, when the patients discharged, these SNFs didn't know who the primary care were or the specialists, so they would just give the discharge summary to the patients and then hope that they'll follow up with the primary care. So, and then amongst home care and hospice, now they've transitioned now to home care or hospice, and mostly home care, we would start getting notes to indicate, hey, we need you to sign these orders, we need you to fill out the face-to-face thoroughly, sign the plan of care, and to our providers, like, we didn't order this, I don't know why they need it, and so obviously you would have, they're requesting for the provider that ordered it, which would be the hospitalist, which that's not going to happen either. So there was a huge component where they're going to discharge our patients too soon because they weren't getting orders signed. And then the other component is that they're worried that they would not get reimbursed for the care. So I think this is probably an ongoing issue you probably all experience. So this is nothing new. And then there's another component indicating that in the end, who's overseeing this patient, who's responsible. So for us, they decided to say, you know what, how are we going to figure this out? With our post-acute partners, we decided to focus on the 2 C's, which is communication and collaboration. For us, that we felt that was the cornerstone, is that if we partnered with these home care agencies and these facilities, we can work on a unique transitional care model that's centered around collaboration and communication. So for us, we had established a TCM hub, which that would be just a team of individuals. For us, we have a pharmacist, nurse that contacts the patients for TCM. We have someone that oversees our transitional program to ensure that it's running effectively, we're billing, and then we have an operations specialist as well that imports all the records, indicates who discharged for that day. And then for myself, I serve as a role of more the ongoing training and education in the community and helping to advance the program. So for us, I do think it's important to establish this hub is what we established with a healthcare, electronic healthcare, more HIPAA compliant, where no system mirrors the same system. So we didn't have changes. We didn't ask any of our home care partners or any SNF settings or hospitals to say, let's all change to one platform. We decided just to identify a HIPAA compliant app and had everyone centralize all their communication there to our TCM hub, which is all of our groups there. And a quick tip on that is that how do we pay for that as a healthcare provider group on an outpatient setting, right? There's a lot of resources, it's very costly to be able to share all of this information to post-acute partners or your community. We actually asked our partners to sign on and then add us into it. So if they wanted effective communication, they would add us on as a team member of them. So between us, we have four home care partners in hospice. They just each added our TCM hub into there, which has been great. They are requesting for appointments, orders, effective orders. I mean, I guess, hey, this patient looks like they have an onset of a UTI. Is there any way, I'm here now, is there any way I can obtain that? The hub will automatically see that, inform the doctor, and send an order that's signed immediately. So there really is no delay in care. I think the longest a patient had to wait on care is maybe less than an hour, whereas normally you would call in as a nurse on the bedside or in the home and ask for that, and a voicemail. Leave a voicemail that MA will eventually get to at the end of the day, and by then you have seen multiple patients, and that patient's probably ended up in the ER. So we felt that this is the best place, that we had to take that on. And to implement a program with centered around our post-acute partners is really challenging, I think. It's an ongoing battle, right? There's never, you don't cut off right at 5. There's always gonna be emergencies that happen after hours. For us, we were able to center our time to be able to cover at all times. So even in the evenings when they have to transition, hopefully to avoid them going to the ER. The other component is to always set expectations. So it's so important to set an expectation that centers around everyone's workflow. I think it's really challenging for us to say, this is what we want you to do, and this is how. I had to really understand what home care, how they operate, and how their nurses operate, how orders go through. And it's hard for us, I think, as a primary care providers, that we just say, we just tell you what to do and you just do it, and then we just hope that everything goes well. But we really needed to become where they became like our an extension of services for us. In skilled nursing facility, every facility, even though you're under maybe one umbrella and there's multi facilities, every facility operates so differently. So it's important for us to engage and learn who those individuals were in each of these settings in order to form realistic expectations, but also this relationship where it's fostered around actual humans. So you have a real life, real-time central hub where you can communicate all the needs to the patient, but we know who we're interacting with. So it's not just a technology platform. And overall, I think the case exemplar is how do you utilize the hub? So we asked, the expectation was as soon as say a home care agency gets a referral from a skilled nursing, that helps capture those ones that say for whatever reason our TCM program didn't capture. So, hey MJ, we got a referral from this hospital and they transitioned to a SNF, they're discharging tomorrow, can we schedule an appointment for TCM? We'll help schedule that appointment. The home care nurse will actually go out to see them, do an admission, and then remind them of their appointment. For whatever reason, if they can't get to that appointment, we'll reschedule it, or we actually were able to develop a Granger at Home program, recognizing that a lot of our patients couldn't go to the clinic timely within that 14-day window. So we would send Granger to the home, which was super effective for us, and then we were able to obviously bill from that standpoint. So obviously there's a huge return on investment, but we're helping to save that, preventing that readmission. The other component was that as soon as the patient's admitted, the home care nurse will automatically put a home care admission on there. This is super nice. We don't really tell them exactly what to do, but it's more than just saying patient admitted to home care. They have all their meds, they have a caregiver, this is what they're doing, here's all their appointments. They have difficulties with transportation, whatever that is. We were able to capture multiple components of, say, patients didn't pick up their meds, or they picked up the wrong med, or they're taking several of the same class of meds, or whatever the case is. But this is one of our exemplars, an 87-year-old female discharged from a facility. She did not have a current primary care provider because they had just retired. For us, we were following this patient through a specialist, so I think it was a urologist, so we weren't the primary care, but we still followed to track them for TCM. As soon as she discharged home, our home care partner went out to see them, established that she didn't have a primary care, but she also was discharged without her life-sustaining medications, which is, at the time it was insulin. They gave her syringes, but there was no insulin for her to be able to provide that, and obviously she only got like one injection before she left. Immediately we were able to utilize the hub. The nurse notified us immediately upon admission that the patient was no longer, doesn't have any medications, doesn't have a primary care to fill this. What do we do now? And to us, we're like, our urologist most likely is not going to fill it, but we need to get them an appointment with a primary care. But fortunately for her, primary care would be able to see her in the next 6 days. But she needed something now. So what our thought was, it's one of our SNF partners, let's reach out to the medical director there. And this happened all in the hub, and just said, hey, Jessica, is there any way we can get a script for insulin to be sent to the pharmacy? This is who she used. Within an hour, that patient's daughter was able to pick it up, and then there was no adverse event that happened. I think without that communication, we would have never known what the patient's needs were. But what was so great is that all of that, the credit really goes to that home care nurse. For us, we facilitated a lot of care, but actually in the end, without that communication, I don't know if that patient would have, most likely she would have resulted back in the ER. So this is just one of many exemplars. This is an ongoing issue that we have all day, but we have identified so many adverse events that could have happened but prevented it just through this hub. So outcomes, quality of care. Now our patients are indicating that not only do our providers know them well, they have everything that they need. We send a full-on summary of what's going on with the patient. So anytime that our patients are seen with our provider urgently or scheduled appointments, our providers know exactly what's happening. For the TCM hub, which was really great, is that we really get to know who our patients are. So you can understand that there's a baseline, and if you notice a change, we can say, hey, is there any way? And through our ACO, we get to do the 3-day waiver. So we can transition patients successfully to a SNF if needed. And so we're preventing a lot of hospitalizations from this, or the unnecessary healthcare costs of keeping them in the hospital for 3 days. And ultimately, our providers are a lot happier. Their patient satisfaction has gone up. reduce healthcare costs. I think for us, it's hard to measure how often we prevent it. There's not a preventative metric where to say, hey, because you did this, this is how much money that you actually save the healthcare system. That's something I think you have to manually track, and it's all through patient stories. But overall, I think that the healthcare cost is all based off of collaboration. Everyone's accountable for this patient, regardless if we're primary cares or not. Whoever's involved in their care is responsible, and we've been able to significantly reduce our healthcare costs. For us, our ACO is, I want to say maybe 2 years ago, it was ranked 6th in the nation for lowest costing care. So super exciting for that, but I also think that there's so much more to do, and we just wanted to continue to advance this. Our readmission rates since obviously in 2013 was at 23%. We were able to reduce that down to about 11% in 2018. And I do want to say that it is the transitional care program, but without that communication collaboration component in that protocol, we would not be as successful. And like I said, it's been difficult to be able to track all of the preventative measures that we've had in place. Patient satisfaction, patients are now indicating that they are being cared for efficiently, and that this is the true urgent care scenario, where if they urgently need something, we conveniently provide that for them in the home setting at their convenience if needed. And then improved outcomes. Our home care partners have indicated, I think overall, there's been a huge metrics with CMS guidelines that star ratings have raised. One of our home care partners, their readmission was at 18 when we first started with them back in 2015. They have reduced it down to about, I'm gonna say 6%. 6 to 9%, kind of depending on which metric you're looking at. And then overall, their star ratings are reduced from 3 to 5. And what's been great is that we didn't just ask them to do this for our patients, right? We do want our patients to have the highest quality of care, implement this transitional care initiative with them. We've asked them to do it for every single patient out there, so it's become a standard of practice for them and in the SNF settings. And for us, I think that overall, our community has really, move this mission and move the needle forward in order to provide higher patient care. And for us, there's been a lot of other healthcare systems starting to adopt the TCM program, and our community is very well aware of what the expectations are. So we've kind of changed healthcare and moved the needle a lot in the Utah setting. And then it's become a patient-centered medical home. So we truly are able to provide the highest quality of care from the home setting, from a SNF setting, home care, wherever setting that is, office setting, and we have multiple resources. In order to implement this is where you start to identify where primary care lacks as well. We didn't communicate quickly back to home care. We didn't do well of notifying our healthcare systems, our hospital systems, and our payer systems that this is where our patients are, this is what's going on with them, these are things that we have worked on, we know that they're failing, we need to have another initiative for them. So for us, I think that it's a true patient-centered medical home for our patients, and I do think that we are providing high quality of care, and it really is centralized over where we're utilizing real humans to utilize on a technology platform rather than having a technology platform provide us with the care and just say this is what's going on with your patient. So, and then there's always going to be limitations in a setting. I'm not saying that we solved healthcare's problems. There's always going to be miscommunication. There's always going to be gaps in the care. And I think our ongoing concerns is that scaling this. Unfortunately, we are not able to do this for every patient in our on home care or in skilled nursing facilities. It's really challenging. So we've only centralized our hub for the ones that go home with our partners. So they have access to this hub, and it's the best way we knew how, but our thought is that if we can encourage our community to utilize our patient panel of preferred providers, with the exception of patient preference, right? And so that's what our biggest ongoing challenge is that no network or collaboration mirrors the other. So say insurance companies, they have a collaborative, they set up, a hospital system has a collaborative, SNFs start to set up collaborations, and then when you go in there and indicate, hey, this is one of our patients, like, well, they came from this hospital, and then it's this insurance, they asked us to use this, so who do you utilize? Which collaboration is the most smart? So for us, I think we feel that we've had to train our SNFs to understand the long-term impact of what could happen if they don't utilize our partners, but it's all manual, you have to track it, and you have to prove it to them. The other component is that for us, I think cost, I mean, there's a huge return on investment for us, but it's hard to prove to a provider group that it's a physician-owned practice to say we need more we need more staff to be able to run this. The other component is turnover. Regardless if you have physician turnover, you have MA turnover, right? You just change this whole entire system internally, what to do, and then you get a ton of new MAs and a ton of new receptionists that you're constantly training. There's a lot of turnover in the SNF industry, obviously, whether it's an administrator, discharge planning is a huge thing, DONs, and so whoever's captured the spirit of the mission, they leave. They don't technically leave that mission there. So we're constantly going back in and out of, so it's hard for us to kind of advance with certain facilities or certain elements of this because of that. But what's been great for us is that our home care partners have always remained the same in the past 4 years that we've been doing this with them, is that we've had the same liaisons, we've had the same leadership, core leaders, and so if anything, I think that was our biggest component, is that regardless if the SNFs transition and our providers and our staff transition, is that as the home care continues to do that as a standard of practice, then we really are going to be able to continue this mission in advance. And then overall, I think that we, like I said, we just can't be everything to everybody. And so we have limitations in terms of providers not being able to see our patients quickly enough. We have established that at-home program, but could we scale it? Absolutely, but how do you do that when you would have to hire on more people? So we just have to constantly prove to our provider groups that this is working and what we need in terms of resources. And overall, the amount of work that we do, I mean, it's a day and night job, right? It's a program that never sleeps, and you can't bill for, like, say, compassion or sincerity to help with our patients. But I think overall, like, our ACO has seen significant progress and advancement. And if anything, we love sharing the platform. So it's not a trade secret for us to keep this program and how do you do. We're always happy to help offer resources and letting anyone know where, hey, we're stuck on this phase and we want to continue to advance, but how do we do that? And so it's so I'm very fortunate to be able to. We have a grassroots operations. We've identified all the challenges. We've overcome a lot of those challenges, and we want to share it with our community and on a national scale. So, I feel like our limitations are probably more of opportunities for everyone to learn together. And then questions on that. I kind of went kind of quick, but just want to make sure that there's enough time for everyone to ask questions if you have any.
All right, so this is really cool. Great presentation, thanks for sharing. And I may have missed a tiny bit, so can you talk a little bit about how you engage and you enhance sort of the collaboration with the inpatient teams that are actually discharging the patients to the facilities, and how do you get engagement there and keep engagement?
Yeah, that's a great question. I think engagement, when you let them know, when you're a part of a large collaboration like an ACO, where you're connected with provider groups that are streamlined to referral sources, you get a lot of engagement that way, but you have to prove it to them, right? For SNFs, from a primary care standpoint, SNFs don't think that we are sending patients to them, right? They're thinking hospital systems. So it's important to connect with hospital systems because they're also trying to prevent readmissions, and then working with them to say, like, our affiliate is, this healthcare system, this provider group, this orthopedic surgeon. So it's been really, I want to say it hasn't been as challenging on our end to get people to be more engaged because they know there's a huge referral stream. I mean, obviously Salt Lake City, Utah is a smaller community, so it's harder, but they recognize who their best referral sources. For home care, there's another component, right? Not only are they getting referrals from hospital systems, but our providers trust them more now. And so all of our providers, front and center, they don't even need to send it to me to refer out. They're already indicating, like, this is who we're gonna send this you to, because this is what's gonna happen. We're gonna get all your communication if you need any help during that time frame. So that's really where the engagement has come from, but so I hope that's helpful, but it is hard. I think it's hard to get hospitals on board until you can prove it to them as well.